Hi, I think we'll start today. It's an honor to actually have two of our own presenting at Medical Education Grand Rounds. Both of them submitted to the 2010 Medical Education Research Day, and they were the two blue ribbon winners for the highest scores. The submissions are actually rated according to Didactics criteria for scholarship. So there are 5 categories: clear goals, appropriate methods, evaluation plan, results, and reflective critique. And both of them got the highest ratings out of the 39 abstracts that were submitted last year. And we showcased their posters at the National AAMC conference this past November at the Mount Sinai booth. The first person to present is Dr. DeMaria. He is instructor in the Department of Anesthesiology, the Division of Liver Transplantation. He went to medical school at UMDMJ, Robert Wood Johnson, did his transitional year internship at St. Barnabas, and then has done his anesthesiology residency here at Mount Sinai. While at UMDMJ, he was inducted into the AOA and the Gold Humanism Societies. He also received the UMDMJ Academic Achievement Award for excellence in all courses and disciplines. While at Sinai, he's had the distinction of being named the first Elias Berg Research Scholar in the Department of Anesthesiology, Resident Researcher of the Year, and the Institute of Medical Education's Resident Educator of the Year. He's interested in research, looking at novel ways to approach medical education and the use of simulation in detecting and preventing medical errors. He's going to talk today about adding emotional stressors to ACLS and how that enhances participant performance.
Yeah, I left the blue ribbon at home. So this is my chairman affectionately knows this study. This is the We Tortured Medical Students study, but I won't refer to it that way because I don't think that's what we did. I couldn't start this presentation, and thank you, Erica, for that very nice introduction. I couldn't really start without a shameless plug for our nationally endorsed simulation center in the Department of Anesthesiology, where we're educating medical students, residents, and now attending anesthesiologists are coming and doing recertification courses, remediation courses, and all sorts of fun stuff where we're torturing them as well. I have nothing to disclose, although I will say that this blue ribbon and poster ended up being published in Medical Education. The preliminary data was presented here, and then we got it into a journal, so they fell for it. So the only disclosure is that some of what I'll be presenting to you today is already published, and I'm not plagiarizing myself. I'll just be sort of showing you some of the things that we've done. So a little bit of background. I know we're short on time, but I'll sort of make this very brief. Emotional learning, as we're sort of calling it, is conceptually easy to grasp. You know, how does anxiety, how do emotional stressors affect the way we learn? Are they good? Are they bad? Are they indifferent? Well, it really depends on what you mean when you say learning. There's really good evidence that if you're under the right amount of stress, emotional stressors, and as long as they're sort of congruent with what you're learning, they can help encoding and consolidation of memory, meaning that you lay down the memory and you hold on to it a little bit better when you're under stress. It's sort of the reason that we all remember where we were when certain bad events have happened. And on the flip side, stress tends to impair retrieval. It's the reason that when I was 12 years old and a girl kissed me, I forgot what my name was for 5 minutes. When you're really stressed out, it's hard for you to remember things that are very, very basic to you. But what's really not clear is how novice learners do if we stress them while they're attempting to gain new information. The conventional wisdom holds that if you stress out a novice learner a little too much, they'll be unable to really lay down the memory. So that was one thing that sort of drove a lot of this research with that question in mind. So we'll table that for a moment, and there's a little background on sudden cardiac death. It's bad. All hospital-based physicians have active or should have active ACLS cards, and we do this presumably adequate bi-yearly renewal where we go somewhere and we roll our eyes for a couple of hours and we do a mega code and we get our little card. And and I've only showed 2 studies here, but study after study has shown that within about 3 to 4 months, everything you've learned, even if it's not new for you, is pretty much flushed down the drain. And this is not inconsequential, because if you actually go to a code, and they've done this in several observational studies, and you watch how they're run, they tend to really deviate from ACLS guidelines. So there's a need here. There's definitely a need. And a little extension of this background, well, what happens if you add high-fidelity simulation to an ACLS course? And when I mean high-fidelity simulation, I mean the room looks like an ICU bed, there are actors there that are ICU nurses or interns, and the environment is really close to what it would be like when you're running a code. Time after time, it's been shown to actually improve retention. But there are major issues here as well. It's very complex, it's very costly, and the bells and whistles are very expensive. The machines that we use 2 Medi HPSs, and they're both $250,000 each. And then you need the real estate to house them, and you need all the other accoutrement that goes with them, and you need to pay me to be out of the operating room for a little while, and I'm now expensive. It's kind of cool when you're no longer a resident, and then your pay scale goes up, but then you can't hang out in the simulator as much anymore. So another question that comes up is, well, what is it about high-fidelity simulation that makes it actually improve retention? So with these things in mind, we developed a few hypotheses. One was that scripted stressors in an HFS learning scenario of ACLS would lead to greater anxiety. This is sort of an easy one. If we yell and scream at you while you're doing your session, you'll probably be anxious. This is myself and Andrew Schwartz, who's one of our simulation fellows at the PGA, which is the largest international conference for anesthesia. This is us doing an airway fire with a bunch of participants. In my one hand I have a scalpel, and my hand that's down here I have a bovie, which I shouldn't have had for that sort of tracheostomy. What you don't see is that, or what you don't hear, is that I think this participant, I think she was from Germany, and although her accent was very thick, what she said was expletive. I can't believe I got an airway fire. I'm supposed to be on vacation. So this is sort of us stressing out the masses. So that's one hypothesis, that we could stress you out. The other, and the big one here, is that this anxiety that we thought we'd be able to create would actually lead to enhanced ACLS knowledge and skills. And the reason I said scripted stressors in the first hypothesis is that this is sort of a typology of the fidelity of a simulation. Usually psychological fidelity, environmental fidelity, and equipment fidelity are the things that you need to make something a high fidelity simulation. Most people are completely focused on equipment fidelity. If I get the really expensive toy, it's got to be better. And then the next step up from that is usually, well, it should really look like the environment. So environmental fidelity, those two things, but if I have those, it's going to be fine. And what often falls to the wayside is psychological fidelity. Is the situation does it not only look and feel like the real situation, does it feel intensely emotionally like the real situation? Is it like a real code? Are people really frantically going back and forth? Or a team of medical students standing at the door obstructing their way to go in? So that's sort of what we're interested in my group. Methods, well, I'll blow through some of this. We sent a mass email. The first 25 participants that we got from the first and second year classes, we enrolled them because that was really all we could handle with our staffing. And we randomized half to a study group, which we called the emotional content group, and half to the control group. And we divided this into 3 phases. Phase 1, they all came in and they got a didactic ACLS course, which we pared down a bit just to stick to malignant arrhythmias. We didn't do the full ACLS with them, so they didn't get a card after the end. But when they showed up, we tested their baseline heart rates. We had them do the state trait anxiety inventory, just so that we knew if they were terribly anxious people or not anxious at baseline. And we had them do an ACLS multiple choice questionnaire. Phase 2, they came back about 2 weeks later individually, and this was their experiential session. And this is where they were randomized. One group had the control, which was more traditional ACLS teaching, with the mannequin there. They were expected to be the team leader, but we would help them and coach them along if they stumbled along the way. And then the emotional content group, they were also expected to be the team leader, and we would also help them if they needed it, but things got a little hairy, and I'll discuss exactly how. After they did that session, and throughout we monitored continuous heart rate. But after the session, we did more state trait anxiety to see if they were really revved up from the session, and another ACLS multiple choice questionnaire. And then 6 months later, because we wanted to be out of that 3 to 4 month decay period, we had them come back. We had them do a code as the team leader, which we videotaped and had 2 blinded raters rate for performance. And we also had them take yet another ACLS multiple choice questionnaire. So I kind of discussed this already. We just did this very simple didactics course in phase 1. In phase 2, they came back to our lab 2 weeks later on their own, meant to be instructional but immersive, meaning, again, they were supposed to take the role of team leader, but we would help them out as needed. And they were fitted with a heart rate monitor. This was their scenario, more or less an older gentleman who has surgery, is currently in the PACU, has some ST changes, and he sort of progressively tumbles after that. And then this is how they were different, or how they were the same, and then how they were different. The control group and the emotional content group both had their phase 2 session done in the same setting, in our sim lab. They encountered the same scenario, which we just call ACLS test. They were to play the same role, which is team leader, standing at the foot of the bed. And there were the same 3 actors in each session. Someone playing a nurse, someone playing an intern, and someone playing a family member. How they were different was how these actors behaved during their session. In the control group, the family member, when they see something's going wrong, says, should I leave? And then they leave. The intern is very, very helpful with chest compressions and pushing drugs or whatever they want them to do, and the nurse is equally helpful. The emotional content group is really, really nasty to watch. The family member starts screaming and crying and carrying on and won't leave the room if asked. The intern suggests lots of incorrect interventions, shock asystole, and then at some point walks past the simulator and knocks the IV out, spilling fluid all over the floor. And the nurse keeps saying really inflammatory things like, we're all going to get sued, and at the end actually makes you pronounce death to the family member. So after that was, again, we debriefed them, we did a post-test, and then we did state trait. Again, 6 months later they returned to us, and we retested them. When they returned to us, we didn't deliberately stress anyone. We just had them encounter a code scenario. So what did we actually find? Well, the groups were well matched, so we were happy about that in terms of age and class rank and gender. We induced anxiety, so hypothesis 1 was fairly successful. If you see, resting heart rates for both groups were similar, as you would expect. But during the scenario, the average heart rate and the maximum heart rate for the group randomized to emotional content was about 20, 30 beats higher. And their state anxiety scores at the end of that scenario were much higher. So they were feeling it big time. So the real question then became, well, did this work? Did it do anything? And this is just sort of representative heart rate data. This is sort of what our data looked like when it was smooth. The solid line is your average emotional content group participant. And what's kind of cool is that the bumps each way along the way. I think the first bump was when he actually arrests. The second bump was when I think the IV gets knocked out, and then the third bump at the end is, oh, by the way, could you tell the family member that their father just died? So what happened, which was kind of interesting, is that we enhanced their performance, but not necessarily their written knowledge of ACLS. If you see the pre-test score, they were both abysmally low. They were scoring in the 30s and 40s, as you would expect. They had never encountered ACLS before. After we taught them a little bit and they had a session, their scores came up nicely into the mid-70s, again, as you would expect. And their final score, 6 months later, still in the mid-70s, which is actually reportable in and of itself, that they retained the knowledge better. But that's in line with what we would expect from high-fidelity simulation, that their knowledge would not decay as rapidly. But what's really important here is the performance score. 2 ACLS certified attending anesthesiologists watching and blinded to the group assignment pretty much unanimously with a rank correlation coefficient of 0.97 agreed that the emotional content group performed much better in the role of team leader than did the control group. So what did we learn? If you carefully script high fidelity simulation, you can induce anxiety, and that this is actually a modifiable variable of simulation. That it's not just about the simulator itself. It didn't necessarily affect written test scores, but what was really important here is that the performance was improved. And in the end, with ACLS and any skill like it, that's really what you're after. Can these people perform on their feet as opposed to sitting down and fill out the multiple choice questionnaire? It didn't cost anything for us to make our actors mean and nasty. Novice learners were not hampered here, and actually most of them really enjoyed their experience. And I think a really important question now is, does this have a role in low fidelity simulation? In the simulation we're currently using for ACLS, can we add these little bits of emotional content without having to send someone to a really expensive center and make it cost prohibitive, and just add it to the current teaching that we have with the current equipment we use, and maybe just get them on that, that inverse view of the Yerkes-Dodson law and sort of rev them up just enough so that their performance is really enhanced. These are some references. Thank you very much, and I'll take any questions you have.
Thank you. That was an outstanding study. Did you interview the medical students or afterwards debrief them or ask them what they thought about the experience?
Yeah, at the end of the phase 2 session, we debriefed just to kind of go over the knowledge portion of it, and also we were trying to get an idea of how they felt. And then we again sort of offline talked to everybody at the very end. It's interesting. They all endorse feeling stressed out being in a simulator because they're just on the spot, and there's something very stressful about performing in front of others and doing something in front of others. I mean, if I have to, and I do this all the time with all sorts of people, but if I have to stand in the hot seat and put the tube in front of all of you, I'm going to for a second be like really nervous and then just do it. But there wasn't. It didn't really seem that one was greater than the other in terms of just being anxious.
Okay, and then two other quick things. One, what did the medical students understand when they were enrolling? Did they know that half of them were going to have stressors, but not what kind?
Mm-hmm. Yeah, they knew that there would be a component of stress, and they didn't know from where it would come. And I think they all thought they were in the stress group, which was kind of interesting.
And then lastly, clearly they started with very little baseline knowledge. The question would be, how much of an impact would it be if your knowledge was up to 70th percentile?
Right. There's no clear answer, at least for ACLS. And the reason we really chose it is not because ACLS is totally interesting, but there are really good formalized measures for what's good performance and what's bad performance. There's one study with critical care nurses, and it did something very similar after our manuscript was published. And what they tested was not knowledge. They tested that on repeat sessions or in actual codes were their stress levels lower. And they found that people that were trained in a very stressful situation, when they performed ACLS or critical care in their actual environment, their heart rates were lower and their endorsement of their own stress was actually lower because they sort of had already been there and had already seen it. And so it was sort of another day at work for them. So it's not yet clear from our perspective for ACLS for people that already know it, and that'll be an extension of our study, and we're working on doing that eventually. Mm-hmm. Yeah, actually, anything over. I'm sorry. In the interest of time, what I really should have done is shown everything with the kappa statistics, but these are validated from the AHA, and they've been modified by this author D. Wing, who's done a lot of work on this and validated the measure itself. So we just stole his measure. Yeah, anything over 22 on this particular scale is considered a mastery level of ACLS, whatever you take that to mean. And anything above 30 was usually seen by people that were critical care trained or anesthesia trained. They tended to just sort of ratchet through it fast.
The other point is trying to think back to the last time I ran COVID, working with pediatrics. It's only not representative kids that taught them. So whether those are, whether there's any information about what people who are going to code actually face the biggest stresses for. Because I can imagine that a code, a nurse, a family member, and an intern is interesting, but there might be other stresses with fellow residents or attending, and whether you have any plans to study any of those.
That's actually very interesting. I mean, it might be nice to do an observational study and kind of get at that. No one's ever really looked at what about it is stressful. We just sort of take it on faith that it is stressful. But no, yeah, that's actually a great suggestion. Maybe it's worth for us looking sort of at the same time while we're doing it in the lab. We can probably learn a lot to make our scenarios a lot scarier as well.
I don't know the breakdown of the performance score, but I assume that there are some categories on communication and
Yeah.
some on performance. Was there any difference in any of those categories? In other words, the impact of stress, did it enhance communication or performance or?
They seem to be better across the board. Interestingly, there were 4 components to the rating scale, and it was communication, knowledge. It was sort of modeled after ACGME core competencies for the most part, plus minus. But across the board, they seem just better. But I will tell you, even though I wasn't allowed to be a rater, and when I looked at some of the videos, they were just much, and it's hard to quantify this sort of a thing, but they were just much cooler and more collected. They kind of sat there and they pointed at people and they said, you need to do chest compressions, you need to give drugs, and they were just it was pretty impressive actually. So. All right. Oh, sorry. No, they did not. We thought maybe they would, but I think actually that probably has more to do with our sample size. Just like any simulation study, our N is always abysmal, so that probably could be parsed out if we had 100 people or so. Thank you very much.
Next, it's my honor and pleasure to present Dr. Gabrielle Goldberg, who's actually a homegrown Sinai person. She did her medical school training, residency, and fellowship here in hematology oncology, and she is currently the education director of the Lillian and Benjamin Hertzberg Palliative Care Institute of the Brookdale Department of Geriatrics and Palliative Medicine. And she will soon be the medical director of the inpatient palliative care unit when it opens hopefully in April. Her career interests have revolved around medical student and resident education, around palliative medicine, and actually management of pain. And she's going to present the work today on the impact of a 1-week clinical rotation in palliative medicine on medical student graduate experiences and preparedness in caring for seriously ill patients. Happy?
My fingers are cold. It's hard to make them work. Can you hear me? Yeah? Okay. So it's a very long title, but I'll take you through exactly what it is that we did. But the objectives of our study was to describe the third-year medical student clinical experience with the palliative care team and to review the impact of this rotation on graduating medical students' experiences and preparedness in caring for seriously ill patients. So I first became the education director in October of 2006, and the academic year 2006-2007 was the first year we had all of our third-year medical students required to rotate with the palliative care team. And I think we would all agree that all physicians must learn to care for patients facing serious illness, particularly in the areas of pain management and communication. But there's little data specifically evaluating the impact of a clinical rotation in palliative medicine on medical students with knowledge. And if you actually review the medical literature and medical education, few medical schools have a required rotation in palliative medicine, and many of those that do have a requirement have a one-day experience where medical students are sent to go visit with a hospice patient for a day and have didactics they sit in a classroom. Very few of them are actually hands-on involved in caring for patients. So as I said, starting in July 2006, all of our third-year medical students were required to spend a week with our clinical team. And that rotation consists of spending time with us, seeing patients, seeing new consults, seeing follow-up patients with our multidisciplinary palliative medicine team, which there are always 2 teams on service, each of which consists of an attending physician in palliative medicine, a nurse practitioner from the palliative care team, At that point in time, we had a social worker for both teams. Currently, we have a chaplain, although at that point we did not. All of the students also attend Didactics in team management and communication. And prior to 2006, all of our medical students had the same Didactics in the classroom, but didn't have the actual clinical experience with our team. So I took over, and we had all of our students doing this rotation. I said, isn't this wonderful? But how are we going to know if we're making any difference by having them spend time with us? And we didn't have the flexibility of saying what was their knowledge before, because we were already spending time with many of the students. So we decided to do a graduation survey that year in 2007 and use those graduating medical students as our baseline group. And then repeat the questionnaire in 2008 to allow the students who had spent time with us to show what they had learned. So our methods were historical control trial with the class of 2007 serving as our control group and the class of 2008 serving as our intervention group. And what we did is we invited all students to participate in the graduation survey in the month prior to graduation, and we offered a $10 Starbucks gift card for their participation to help promote students in their last year before they leave to help us out. So our outcome measures were a survey, which was adopted from a tool developed by David Weissman at the Medical College of Wisconsin that he is currently using as part of the medical school Palliative Care Education Project, and he uses he refers to it as a needs assessment for fourth-year medical students to see what they know and what their needs are for learning. In the survey, the students are asked to self-assess their knowledge and their feeling of preparedness in caring for seriously ill patients in a variety of different parameters. We also asked the students to complete a 30-question knowledge exam in palliative medicine, which is very similar to an exam that we give as a pretest for our medical students to help them guide their learning over the course of the time they spend with us. And then for the intervention group, we also added 2 additional open-ended questions. One was name 3 clinical skills you learned during the rotation, and the other was to tell us how they had used their skills during other rotations or at other points in time. We expected, as the students are told at the objectives for their rotation, are very clearly told to them when they start their rotation in geriatrics that they're expected to learn about team management. Nothing more specific than that. And they're also expected to learn communication by observing at least one family meeting over the course of their week. So that if by Wednesday or Thursday they haven't had an opportunity to do that, they're supposed to bug us and say, when will there be a family meeting, and make sure that they get that experience. We also took a look at the AAMC graduation questionnaire for the classes of 2007 and 2008. So our statistical analysis, we used paired t-tests to compare scores on the knowledge exam and used chi-square tests or Fisher exact method for items in which data was unequally distributed to analyze the remainder of the survey results. And for the open-ended questions to evaluate our qualitative data, 3 authors independently reviewed and coded and then reached a consensus. Themes and categories were derived by inductive methods, and all qualitative comments we used grounded theory and a constant comparative method of analysis to reach a consensus in classification of the responses. So we had fairly okay response rate. We had 55% of the class of 2007 responding to our survey, and 50% of the class of 2008 who completed the survey. The 2 groups didn't differ in terms of gender, age, or residency training plans. And the class of 2008 reported higher ratings in terms of the quantity of palliative care teaching that they received compared to the class of 2007. Unfortunately, there was no difference in the mean knowledge score on the 2 exams, with 65.7% for the class of 2007, 67.7% for the class of 2008. In some ways, it's not surprising, as was just mentioned before. Retention of knowledge over time is difficult to document, and for some of these students, graduation was almost 2 years since they did the rotation in July of their 3rd year. Perhaps it wasn't stressful enough, but I think we certainly induced some emotion, which we'll talk about in a minute. And I also will note that the class of 2007 did receive the same didactics, so the actual content of information they were receiving in the classroom was the same for both graduating classes. In terms of our other results, in terms of the self-readings, there were several things that were of note. So here you'll see a graph with the class of 2007, class of 2008, and how they self-rated their performance and skill in choosing an opioid starting dose and dose titration. So So with the caveat that their knowledge was no different, we did show significant improvement in their comfort level. The class of 2007 rated themselves as poor to fair, but certainly you can see we had a significant change in the shift of there were some people who were much more comfortable and certainly less numbers that were rating themselves as poor. The same was true for their self-rated performance or skill in completing equianalgesic opioid calculations, in providing counseling regarding advanced directives. And again, this type of skill is not a skill that you're able to ask on a multiple choice question. So in terms of the opioid calculations, I think on our multiple choice question there are 2 opioid calculation questions, just to give you a sense of what we really were measuring quantitatively versus their self-assessment. They also documented improvement in their comfort level in discussing DNR order options and in making a timely hospice referral, which we know as a community of medical providers we are in general very poor at. So improving someone's comfort level in having these conversations I think is an important first step, because if you're comfortable having the conversation, you're going to start the conversation and presumably have it, as opposed to let it fall by the wayside. And additionally, the students also were more comfortable in conducting a family meeting, and I didn't show the graph here. So what I found most interesting to me was the qualitative responses that the students provided. So in response to the question, name 3 useful skills you learned during this rotation, as I told you initially, we hypothesized that they were all going to say pain management and communication, because that's what we told them were the objectives of the rotation, what we expected them to say. So 93% of the students provided actual qualitative responses, of which 162 of those were total number of responses, and 157 of them were quotable within one of the categories that my co-authors and I had classified. So in terms of the overall category of communication, there were multiple subheadings. One was in the range of family meetings, which is what the majority of the communication responses were, and we have some representative comments here. Just in general, something like a comfort with family meetings, we very clearly would classify into communication about family meetings. The next most common was breaking bad news, followed by comfort with end-of-life discussions, goals of care discussions, general communication, so somebody that is just a difficult conversations, we classified that as general, advanced care planning, discussion of prognosis, and then the one that I found interest was, in this category, was attentiveness, and one of the phrases that we quoted was knowing how to give comfort with my words. So communication, but not, I think there's a subtle difference from knowing I'm comfortable conducting a family meeting, but actually saying knowing how to give comfort with my words. Communicating with other teams was another category, and then another that we didn't fit into any of these comments. Sure.
I don't understand attentiveness as the category that describes that statement.
So I think what we meant by that is attentiveness to the emotions in the room, and I forget the other phrases that fell in there to give you examples. I think that would probably help you, but the knowledge that communication is not just the physical, I know to bring everyone in a family into a room, but knowing how that part of communication is the comforting and being present and expressing empathy.
So conveying sincerity,
or the sense, the observation that that's an important skill that they learned, and even identifying that as a skill, separate from I know how to talk to people, but I know that when I talk I have to give comfort. And then we also pain was what we expected as the other big category, and then we got a lot of those responses. So pain control, especially feeling more comfortable with analgesics, awareness of non-pain symptoms such as nausea, and then this other category of affective components of care, which in some ways is related to that other category I was talking about, but independently multiple students said things like compassion, empathy, patience, which face value, they're not skills, and it's clearly not an evident part of our curriculum, but I think a very important part of the hidden curriculum that we're providing to these students, that we are mirroring to them how we think a good doctor should behave. And this is different than other rotations. Our 1-week rotation, I forgot to mention, falls within the 12-week internal medicine geriatrics clerkship. So the students all spend 4 weeks doing internal medicine at Mount Sinai, 4 weeks doing internal medicine at an affiliate institution, and then 4 weeks on the geriatrics component of the clerkship. Of those 4 weeks, 2 weeks are spent in the outpatient geriatrics practice, 1 week is spent with the visiting doctors program, and 1 week is spent with us. So we're different than other clerkships because we're not trying to train a pediatrician, we're not trying to train an internist, we're not trying to train someone to become a palliative care doctor, but we want to give them an idea of what it is that we do so they feel comfortable introducing that concept to others. But I think a hidden part of what we try to do is just remind them of what's important about being a doctor.
In the 2007 group, instead of having PALCAT, they had an extra week of Jerry?
That's a very good question in terms of what the extra week was, and I defer to Erica. So I'm not sure what the curriculum was. If that was part of an outpatient. Outpatient. I think even the Martha Stewart, the geriatrics outpatient component may have been new in 2006. Because I recall when I was a medical student, we were sort of sent out to different internal medicine practices outside of the hospital.
You would think hanging around with a bunch of geriatricians would make you compassionate and empathic and patient.
We didn't ask this question of the prior year for obvious reasons. They didn't have a rotation, so it wasn't an appropriate question to ask them. So I don't know what they would have said of what they learned on geriatrics, but we were specifically asking what they learned on palliative medicine.
I find that they learn in this 1 week. Well, we don't know that. We don't know that they'll do. Well, the question is three useful skills.
It's not.
Now, the assumption is it may be the whole mid-geriatrics rotation.
We specifically said did you do it was all in the context, did you take a palliative care rotation, and it was in the context of specifically about the palliative care week. Name 3 skills.
Right. It would be sort of sad if the rest of the 11 weeks of that clerkship. Compassion really is important. Come on.
I don't.
You wrote it on that service, and as a non-geriatrician, non-palliative care doctor who has rotated on that service, it's so palpable compared to, hopefully it's happening everywhere. I'm going to say we hope that it's happening everywhere, but you're dealing with so many people and their family members at the end of their life that it's a palpable skill, I think, whereas other skills it's sort of all integrated.
I think it's how we practice is very different than how an internal medicine team practices. Some of what I do is end-of-life care, and that is clearly emotionally draining and impacts students because it's sometimes different than what they've seen before. But I also see acute pain consults, and when I have an acute pain consult, it is a medical emergency. I will respond to it within 10 to 15 minutes. That may be different than what they're seeing their house staff doing, and I will not leave a bedside until someone's pain is controlled. So because of a variety of factors, because of all the other stressors that house staff have, they have patients who are septic, they have patients, they have conferences, they have a lot of stressors and places they need to be, that they may not be mirroring the kind of behaviors that they see on the palliative care week, that we respond differently to patients and families. And a lot of the comments that we get from students at the end of their rotation is, this reminded me of why I went to medical school. Because you sat and you... Mm-hmm.
I guess what you're saying is this is a uniquely concentrated element of what they see is being done, and that perhaps is part of the attendance.
Mm-hmm. And I
Really a part of unlike perhaps other consultations where the challenges are managing dysfunction.
Well, I said this to an applicant before, and I think that, I guess you guys can't sing your own praises, so I'll sing it.
Thank you.
I think that they are so good, and the students rotate through that service, and the residents in all fields have them doing consults for them, that the hope is that the whole institution, and I think it's true, has become better at this. Their consults that they get now skew more towards, not just end of life, but end of life where, the sister hates the brother, complicated family dynamics, because everyone has gotten better at this because of their achievement. That's my view of this institution, I hope.
We try.
Yeah, I think that's pretty true. At least the medicine residents, I think they are.
I think also the way we teach is very different. That I think when an intern and a resident go and rotate around on the patient with the team, you walk out and you discuss the medical management for the day. When we go and we have a family meeting, we discuss, okay, what are our next steps in terms of medical management? We also say, how did that meeting go? We talk about the emotion. It's not as hidden as I'm suggesting. We say, that was a really tough meeting. Like, I was almost in tears. And how many times does an attending actually say that to a medical student over the course of their training? So I think it may not be as informal or maybe it is a part of our informal curriculum, and maybe hidden is not an appropriate way to describe that part of the curriculum. Yes, they're all all of the medical students during their 4 weeks of geriatrics are encouraged to attend the short center room. In terms of the other comments about communication, they just felt more confident, better able to approach patient and families. And again, in terms of communication and the question of does someone know how to communicate or not, as some people say, either have it or you don't. I think there's plenty of literature now that you can teach people how to communicate. And I think the Oncotalk literature from Bob Arnold and Tony Buck tells us we can teach people how to improve these skills. And being comfortable and putting yourself into the room, and then the act of walking out and reflecting back, how did that session go? What did I do that made it go well? What did I do that I could have done differently to make it go better? Is how you improve your communication. So I think it is a very important thing to note that they feel more confident and better able to approach communication. And I think this is also an important take-home for the students is knowing when palliative care is appropriate and when to call for help. So comments like throughout the 3rd and 4th year rotations, there were often situations when I had to call upon the things I learned during the palliative care block of medicine, and I'm really happy I was given that training. And when I was on the wards or in the ICU, I'd become more aware of goals of care and more comfortable talking about them, and called upon in surgery in terms of pain management for post-op patients, suggesting palliative care be called. And I think this sums up to me a lot of what a lot of different students said, is that after the rotation, I now feel more comfortable dealing with palliative care issues than most of the house staff with whom I have worked. The rotation made me a resource for my future teams. And again, most of the house staff with whom they have worked did not have the opportunity to have a palliative care elective or a rotation. Some of them may have had an elective, but I think that is very striking that that's something that the students walked away with. For more quantitative data, for those of you who like quantitation better, we also looked at the AMC graduation questionnaire, which is a questionnaire that all students are required to complete, so we're able to not have a random sample, but really have everyone represented. And you'll see here in the light blue is the class of 2007, and the dark blue is 2008, and the greenish color is all other schools in 2008, asking the students to rate their level of instruction as appropriate in the area of palliative care and pain management, and also in the area of end-of-life care. And you can see that prior to 2008, the students were much less likely to rate the level of instruction here at Mount Sinai as appropriate, and after the rotation, students were much more likely compared to their baseline group as well as compared to students at all other schools. So my conclusions are that a 1-week clinical rotation in palliative medicine improves graduating medical students' self-assessed skills in pain management and communication, is effective in improving medical students' comfort in the practice of palliative medicine skills, and should be considered for integration into the curriculum in all medical schools. And I think we need to think about how we can improve their knowledge as well as the retention of their knowledge over time. And I'd like to acknowledge Ling Du, who is the statistician who helped us with the statistics, Diane McGuire, who helped make sure everyone got their Starbucks gift cards and helped the students get to where they need to be during the rotation, Rena and Pete, who are my co-authors, and the Mount Sinai Hospital Auxiliary Board, who provided a grant that established the Palliative Care Education Center and support a lot of the work that we do. Happy if there are more questions or comments. That's a very good question. I don't know the number off the top of my head. I will tell you I did, with the intent of starting a residency curriculum, which hasn't happened yet, I did do a baseline survey of house staff using a very similar tool to what we used here, but with a higher level pretest. We sort of kicked up the questions a notch, expecting the house staff would know better. And in other studies using the same tool, looking at house staff and attendings, they've been able to document that attendings do better on this test than 3rd-year residents who do better than 2nd-year residents, so with time you get better. We interestingly didn't show that PGY3s were significantly better than PGY1s on that pretest, but we did show that Mount Sinai students did better than non-Mount Sinai graduates. So, right, and I can't say that a number of them would have rotated with us, a number of them wouldn't have based on when I did it in time. But some of these students were interns or PGY1s at the time, or PGY2s, but none of the PGY3s would have had the rotation. So, the ACGME requirements require the communication, and we certainly help to meet many of the larger components. As part of the geriatric core competencies, a sub-part of those are palliative care components, but I think it's only 3, and again is, pain management, communication, and assistance with end-of-life issues, if I'm remembering them correctly. I mean, that's sort of my pretest kind of looked at that. Did you have a palliative care experience? It didn't go into a lot of details about what that experience was. And because we haven't implemented a new residency curriculum, it was going to be a web-based, and we didn't get the grant that we expected to get to support that. So it's kind of fallen by the wayside for now.
So, aligned with that, does the ABIM expect in the certification exam that residents are competent in palliative care?
I don't believe that there are any. I don't believe there's any of the subcategories. I know for geriatrics used to not have their own, when you look at the total number of questions that are within each subcategory, geriatrics didn't have their own dedicated questions. It was one of those across all the, it could be a cardiology question, but the patient was 85, so it was a geriatrics question. And I think now, as of this year, there are actually a certain number of questions that are required to be geriatric, and not just be an older person, but actually deal with geriatric issues like falls and geriatric syndromes. There isn't any distinct palliative care question, although obviously it would cross over potentially other categories.
Let me go back to your conclusion slide. Based on the student responses, you're entitled to add a 4th bullet, and that is, yes, very modestly, it appears or it may influence student experiences throughout clinical rotation. And I think that's a crucial element to the
So this study is actually in press now with JAGS, and that is part of our discussion to point that out as well.
Yeah, take more credit.
Okay, thank you.
Yeah.
Have you continued to track the students and their experiences, follow the DQ, and then related to the MCQ, did everyone who helped create it agree that those were items that the medical students should have learned in the context of that 1-week rotation?
So we didn't, in terms of the tool that David Weissman uses, which is actually based on something Susan Block at Harvard had initially developed, we didn't change any of the knowledge questions. So it was developed by a group who has used it reliably in other studies. I don't think they've validated the tool, but has been assessed to be important components they should know. And it is a tool that we use for our third years to guide what they should be learning over the course of the week. Another important component that I didn't mention of our curriculum is we do have a pretest debriefing and review session at the end of the 4 weeks of geriatrics, where we go over the pretest. We review all the questions, make sure they have the take-home points, like how do you calculate a rescue dose, 10% of the 20. They leave with the things that we want them to leave with, at least at that hour. And we also debrief in terms of the emotional issues that they may have encountered during the rotation that they may not have had a chance to talk to us about, or come up sort of after the rotation. It gives them a chance to talk about, boy, that rotation was much harder than I thought because, I went home crying every day, which is the rare person, but more often, boy, that was much easier than I thought because I was really afraid that I wasn't going to be able to handle the emotion, and, they're able to kind of debrief with us that way. So we do go over the facts of the questions with them. So at least in that setting, if they haven't seen anything specifically answering that question, like, what is PEG tubes increase the risk of restraints is one question that many people just didn't know the answer to, and may not come up over the course of a week if you don't have a patient who's making a decision about a feeding tube, but that is something we discuss at least in the debriefing session. Again, they're only going to walk away from that with 3 points probably, so all 30 questions aren't going to be retained. Any other questions? Okay. Thank you.